To the next session, which is tricuspid session, the unforgotten valve. It's my great pleasure to moderate this session with Professor Abid. My name is Werner Bardeleben from Germany. We have an esteemed faculty and panel with Juan Granada from the US, Thomas Modin, Augustin Kursen, and Professor Tamis. Without further ado, we would start the session with a life-in-the-box case with Pascal for tricuspid regurgitation by Dr. Aloui. Is here? Welcome.
So thank you for having me. And so it's not going to be a live in the box because we were not prepared to record, but this is a case-based presentation, and I try to make it as rich as possible to look like a live in the box. So this was actually one of our first tricuspid tear patients. She was a 71-year-old female with a medical background of diabetes mellitus on insulin, hypertension, CKD, with preserved diuresis. And she had a history of paroxysmal AFib for which she is on apixaban, a history of chest pain. Last year she had a CT angio that concluded to normal coronaries. And she was followed for about 4 years with internal medicine for some shortness of breath, fatigue, lower limb edema, and she has been admitted last year for a short period of IV diuresis and discharged on 80 milligrams of furosemide, but she worsened her creatinine, so they were obliged to down titrate the furosemide to 40. She was admitted again this year for the same symptoms. She got a short period of IV diuresis, and this is the echo she underwent that concluded to ejection fraction at 50% for the LV, some mild MR, mild aortic regurgitation, dilated left atrium, and as you can appreciate for the right side, the RV was a little bit dilated, but with a preserved function, systolic function with the TAPSE at 22. Mild pulmonary hypertension, but a severely dilated right atrium, dilated tricuspid annulus, and the tricuspid regurgitation was deemed to be severe on the base of vena contracta of 8.8, a Pisa radius at 11, an AROA at 85, and a regurgitant volume of 66. So here we had some elements in favor of a 3+, a 4+. We concluded to a 3+ tricuspid regurgitation. So the patient was referred to the heart failure clinic. She kept being very symptomatic, so she has been referred to the valve clinic. And we have done her TEE. So here's the TEE. This is a mid-esophageal view, 0 degrees for chamber. As you can appreciate, the right side, we have some dilatation of the RV, but mainly a dilatation of the tricuspid annulus, a large dilatation of the right atrium. This is in color that gives some rough idea about the tricuspid regurgitation, not clear idea about it. And this is one of the most important views we have for assessment, actually, of the tricuspid regurgitation and for the tear. This is what we call the inflow, outflow. Here's the inflow of the RV and the outflow with the tricuspid valve here, which it's like the bicom view we have for the mitral. We have the whole septal coaptation line from the anterior septal commissure to the posterior septal commissure. And so here's the aorta. The leaflet, which is close to the aorta, is the anterior one. The opposite one will be the posterior. Here's the jet, the width of the jet in this inflow-outflow view that we measured at 17 millimeters. When we apply the biplane here, we have what will be our grasping view. So this is a very important and interesting view in which we will have to assess for the septal length, essentially, because you know in most of the cases of tricuspid tear, we will use this septal as an anchor to go and grasp the anterior and sometimes the posterior, so it has to be of a good length, a quite good septal leaflet. So here's some anatomy about the leaflets. As we said, the closest one here is the anterior, here's the posterior. And in the biplane view, the closest leaflet to the septum is the septal. The opposite one will be the lateral, so either anterior and posterior. And if we will differentiate that by the crossing, the cutting line. If you are cutting the anterior, this will be the septo-anterior. If we'll be cutting here the posterior, it will be the septo-posterior. So here's our tricuspid valve, quite good length of the septal leaflet. Here is the color jet, large width in the inflow-outflow view, quite not a large gap here. No tethering of the leaflets, which is good for a tricuspid tear. This is the second very interesting view for the tricuspid assessment. And to be more familiar with, I will start with it's a transgastric, but I will start with the transgastric long axis view. As you can appreciate here, we have the posterior, I'll go back. Yeah, this is the posterior leaflet, the anterior leaflet, and we have the posterior tendon, papillary muscle, the anterior papillary muscle, and this is the correspondent in the short axis view. So when we will go back to our short axis view, and as you can see, this is the only view actually, two-dimensional view, that will show us the three leaflets at the same time, or all the leaflets at the same time. So here is our anterior papillary muscle, and this is in systole, the aorta 5 o'clock. So we will have near the aorta the anterior leaflet, the posterior leaflet here, and the septal leaflet here. So it's extremely interesting and important to know how many leaflets we have, because the tricuspid valve is not always tricuspid. It can be bicuspid, tricuspid, or quadricuspid, and you have some anatomies. For example, when you have, as we said, the septal should be a good, unique septal leaflet. If we have a septal which is indented, for example, or two septal leaflets, it will be very difficult to use it as an anchor. So our patient had a true tricuspid valve, and here is the color. Here we will appreciate the jet. From where is it coming? So it's the major. It has a shape which is quite linear, not so stellar. It's going along the anteroseptal coaptation line, starting from the commissure along the coaptation line, and you have even some. If we follow it, we have some jet between the septal and the posterior, but the main jet is anteroseptal. We ended up by bicaval view that didn't highlight any issue here. So if we summarize, this is a symptomatic patient with a severe tricuspid regurgitation. What is the mechanism? What is the phenotype? The RV is, yes, a little bit dilated, but quite triangular, conical. The leaflets are horizontal, no tethering. There is a large dilatation of the left atria, of the tricuspid annulus. So we believe that it is mostly an atriogenic tricuspid regurgitation. And even if we have some HFpEF elements, some dilatation of the RV, it doesn't dictate, it's disproportional. It doesn't dictate the degree of the tricuspid annulus regurgitation, the tricuspid annulus dilatation and the regurgitation. So it's, our patient is symptomatic. She has she's in this range of symptoms, not too advanced in the process. So should we intervene, yes or no? We believe that yes, because the tricuspid regurgitation, the more it's a virtuous cycle, the more we wait, the more the patient will become more complex, the TR will be larger, we will have more remodeling and less possibilities to repair. So if we need to intervene, how should we intervene? These are the options we have according to the disease progress, symptoms wide and anatomical wide. So we think that for patients who are at a low risk in the beginning of the disease process, nothing can beat a good surgical annuloplasty. But the more the disease progresses, the more the TR will be important, the more the patient will be symptomatic, the more we will have the remodeling, and the less the results of the surgery will be good. So we discussed the case. We believe our patient is here. She is not a patient who is in the beginning of the process. So we discussed the case in our heart team. Her Euro score was pointing to a mortality of 4. The dedicated STS score for tricuspid valve repair was pointing to a mortality, in hospital mortality after surgery of 9, which is quite high, and a 3 score of 7/10, which is pointing to a mortality of 34. So this is a high-risk surgery, so by evidence declined by our colleague surgeons, and she will be for a transcatheter intervention. But what type of transcatheter intervention? We have multiple possibilities going from leaflet edge to edge to annuloplasty to valve implantation, heterotopic or orthotopic. So our patient, according to the echo, is fit for TEER. She has a good jet location, a true 3-leaflet DAT, and importantly, a good a gap, not a very large gap. So we decided to do TEER. For TEER, we have currently 2 different devices, TriClip from Abbott and Pascal from Edward. So which device to choose? In our cases, we decided to choose Pascal because of mainly 3 reasons. The first one is that we know that the Pascal device it offers less traumatic grasping actually. And as you know, the tricuspid valve is very, very thin. So, and for the tricuspid TEER, we will have to grasp once, to optimize again, to grasp one leaflet and to go again to another leaflet. So we will have multiple manipulations. So we really want to use something that is the least traumatic. The second reason is this possibility of elongate the system, which is very interesting as we are going to the commissure, so we don't want to be entangled in the cord there. Of course, the Abbott can offer that a version of the device, but we believe that it is less forgiving than the Pascal device. And for the Pascal, we have 2 devices. We have the ACE and we have the P10, so which one to use? This depends on what we will do. This is our line, our jet. And for the tricuspid, we really need to grasp the maximum of tissue because, as I said, we will have to, it will serve as an anchor, and the one device will not be enough. So here, we decided to use the Pascal ACE as it offers a larger grasping distance, and it is thinner. It's 6 millimeters, so we will be able to put here 2 Pascal ACE. And what will be the technique? We decided to start, it's not we decided, the rule is to start the more distal possible near the commissure. Like in any TEER, we have to start the more distal possible because if you put something in between, it will be impossible or almost impossible to put a device beyond because of the shadowing. So we discussed with the family, with the patient about the options, the procedure, the expectations in terms of quality of life, the risk, which is a quite forgiven procedure. This is our setting. It was in the regular lab, not in the hybrid room, under general anesthesia. I insist on the good communication tools, the headsets, because we are working with our echocardiographer, our co-pilot. If we don't hear very well from him, we can get in serious troubles. Ultrasound-guided puncture. Most of our mitral cases, we are doing them with no pre-closing, with just a figure of 8. So we didn't put any pre-close. For the device, it's the same as for the mitral clip. The only difference is that we will be at 12 o'clock for the guide sheath, the hub, the flashing port. And this is the image in the bicaval view. As you can see here, we are badly received by the septum. So there is a large interaction between the guiding and the septum. And if we don't correct that immediately, we'll have what we call a septal hugger. We don't have to. So it's easily correctable with the system by flexing clockwise this knob of the guiding, so that will flex it anterior, and that will make it will make us away from the septum. And we will compensate for the loss of the height by counterclockwising the system to bring the port from 12 to 11. And that will explain this distortion we see in the fluoroscopy, but that was intentional. This is the jet. This is the sheath. As you can see, we allow to our colleague echographer to repeat the images because sometimes you can have some changes in the images. This is our device, come in closed, closing, elongated, closing it, and next we will bring it near to the valve. Here, the next step is extremely important because we have to be perpendicular to the tricuspid annulus, and in both views, so trajectory and position are very important. So here, you see in this view, we are pointing toward the aorta. We need to bring it down here. So for this, we will have to rotate clockwise this knob. And in the other view, we are pointing toward the lateral. So we correct that by clockwise torquing the fin here, the whole steerable catheter. So here we have, regarding the position is quite good. We are quite distal here. It was intentional, but if we needed to pull it back to the posterior, we just pull back the whole system. So this is in MPR, our positioning, our orientation. It's very important to look at the orientation because like in every TEER procedure, you have to put the device perpendicular to the coaptation line, not to have any distortion of the coaptation line. So here we will be at a position of 2 to 8. The next step is to check which grasping is the clasp anterior or posterior. So this is the anterior, and this is the septal one.
Can you show us the results?
Okay. So this was the grasping. The first device with a bad result here, a residual anterior commissure. So we optimized. I'll go quickly. This is in transgastric view. Optimization, multiple attempts for optimization. Here it was a good result, so then we decided to continue by the same bicuspidization of the. So this is the result after the first device. We went with the second device, guided by fluoroscopy, of course. Multiple attempts for optimization. And I show you the gradient was fine, orientation was fine, and this is the final result. I go back.
Just advance, because you showed the procedure actually just in the last 2 minutes.
So this is the final result.
Very good.
The device in 3D is quite stable.
Very good.
So the patient was discharged. She was discharged the next day. We closed with a figure of 8. We instructed her very well for the furosemide, not to stop it even if she is fine, to avoid any SLD.
Thank you very much for the kind presentation. Very good result. I think we have seen, and because of the time, we will not discuss the case, but do it at the end if we have residual time. So I think we just go on to the next, Professor Habib.
Thank you, Dr. Van Bartheleben. Before inviting the next speaker, I'd like to say how much I'm very happy to co-chair this session with Professor Granada, Professor Van Bartheleben, Professor Walid, and Professor Termiz. And I'd like to thank especially Professor Granada for his support, for accepting our invitation to be here in Tunis. It's the beginning to collaborate with TCT, CRF, and the Tunisian Society of Cardiology. I'm sure that you are working together to tighten our links between the society and the TCT, CRF, so thank you. I'd like also to thank Walid Ben Ali for his support to organize this common session. So it's my pleasure now to invite Dr. Quazen from France to present a case dealing about the importance of early diagnosis and treatment of tricuspid regurgitation. Up to you.
Well, thank you very much. It's my pleasure to be here, and I would like to thank you for the invitation. So indeed, the topic is about early diagnosis and treatment of tricuspid regurgitation. So I have no conflict. I just want to quickly show you a case of a patient we had a couple of weeks ago 80-year-old male, permanent atrial fibrillation for the past 10 years. And he has been hospitalized a couple of times for several acute heart failure, not in our centers, but it has been referred in the end. As you can see, very important doses of diuretics, 750 twice a day. The Euro score 2 was calculated at 4% and the tri-score at 8, meaning a mortality at 48%. So if we look also at the severity of the disease, you can see pretty well using this thoracic echo, the restriction of the leaflet. It was a 3-leaflet tricuspid valve and with severe tricuspid regurgitation. Then we're going to look at the right ventricular function. We can assess longitudinal functions. The TAPC was 18, the RV free wall strain minus 19. You can also look at circumferential function. The RVEF was at 56%, and the RVPA coupling with a ratio between TAPC and systolic pulmonary artery pressure at 0.81. So the first question is, what is TR severity? For sure, it's a torrential TR, grade 5. And the second question is, should we treat this patient? And one of the answers is probably too late because we already have RV dysfunction and the tri-score is high. And of course, we can discuss about this later. Of course, we all know that TR is associated with adverse outcome with an increase in mortality for each higher grade of TR severity. But despite these adverse outcomes, TR still misunderstood and undertreated. If you look at the annual TR cases in the US, 8,000 compared to annual MR surgery, more than 1,500,000, probably there is an undertreatment of the disease. And we have an undertreatment despite improvement in the management, both from surgical technique. The trend is in post-op mortality are decreasing, but also it has been shown before that we have now a lot and several percutaneous technologies available to treat these patients. So what are the recommendations so far? So we need to treat patients with symptoms and or RV dilation, but not too severe RV dysfunction, not too severe pulmonary hypertension. And it's tricky to assess all these parameters. When we speak about TR severity, we all know that we have now not 3 but 5 grades with a new definition of massive and torrential TR. And it has been shown before that even at the stage of moderate TR, we have a risk of increase in RV dilation, an increase in annulus diameters, which can lead to an increase in coaptation defects. So it's a vicious circle that has been perfectly shown before. Now, if we speak about TR progression, I wanted to share with you this publication published in JACC Imaging a couple of weeks ago. 1,800 patients with at least moderate TR at baseline and followed by our Spanish colleague. They found that 43% of the patients were non-progressors during the follow-up, 38 were regressors, and 19 were progressors. And we have predictors of TR progression, which were older age, lower BMI, chronic kidney disease, NYHA functional status, RV dilation, and moderate TR. And if you look at the rates of progression, the risk of progression from moderate to severe is 5% at 1 year, 10% at 2 years, and around 25% at 3 years. And of course, progressive patients in the Kaplan-Meier curve in blue were associated with higher risk of adverse outcomes compared to the other groups. So we have seen that RV function is important in the screening process, but how can we stratify this population according to RV function? We have this criteria proposed by the TIVA consortium a couple of weeks ago. We can look at longitudinal, circumferential, and systolic and diastolic function, and of course we have this definition of mild, moderate, and severe dysfunction. We can also look at the RVPA coupling, which is a powerful and independent predictor of all-cause mortality. In all these patients are going TTVI, and with a threshold at 0.41, you can look at this parameter either with echo or either invasively. And finally, to stratify the risk and propose something, we have this tri-score. The TRI-score developed by Julien Dreyfus, it's based on a multi-center evaluation in France, was in the beginning calculated to evaluate 30-day mortality after surgery, and has been shown to be better than Euroscore 2 to stratify the risk of this population. And then he applied this score on the registry, and he showed that in patients with high TRI-score, meaning more than 6, he didn't find any benefit of either technique, meaning it's probably too late to propose something in this population. It's probably too late, but if you can achieve a very good, successful procedure compared to, it's a Kaplan-Meier curve in blue, compared to unsuccessful procedure, you can probably benefit even in high TRI-score. So, try to keep my time. In conclusion, TR is associated with adverse outcomes. We know that we have a progressive increase in mortality for each higher grade of TR severity. We need to keep in mind the vicious circle of TR, and to date, treatment is recommended for severe TR, for symptoms or RV dilation, but not to severe RV dysfunction. I do believe that we should propose an early referral to avoid this kind of severe dysfunction, to avoid poor RVPA coupling or high TRI-score. Thank you very much.
Thank you for this nice case. So we will move to the next speaker, and then we will discuss all cases. And it's my pleasure to invite Professor Van Bardeleben from Germany, and he will talk about
how to build.
How? Yes, because I'm tomorrow. I think yes, how to start a tricuspid TER program.
À droite.
So,
Pour la
up to you.
technique. Voilà. So how to build a tricuspid program? I think a very good sign to do this is already that the room is quite full, and I think it's an under-recognized but no longer forgotten valve. These are my conflicts. If we look into the situation of indications for both surgery, and we don't have to forget surgery, because the rate of mortality in surgery is also dropping, and there are modern techniques like beating heart techniques, also intercostal or subnipple access. So we have to recognize that there is a huge difference in mortality in surgery for repair versus replacement. Replacement in tricuspid valve disease actually doubles to triples the mortality, while repair mortality can be in surgery as low as about 4 to 6%. The pathology is mainly a dilatation in the area of the anterior or the posterior lateral leaflet situation, and there is a flattening of the tricuspid annulus. We know that there is an impact on tricuspid regurgitation on long-term survival, so we should not treat too late, as has been mentioned before. And if we're setting up this kind of tricuspid program, it is important to know that we're enlarging the team from a team on the left-hand side that is more for TAVR, which can be straightforward as a routine implantation now, to a team that involves many more players. And the tricuspid valve, if you move from repair to replacement, involves possibilities like AV blocks or electrophysiologists. It involves much more than any other intervention, imagers, echocardiography, and in replacement or annuloplasty, also CT analysis. So we should think of a larger multidisciplinary team. If we look into the surgical results, we know that the surgeons are also improving their outcomes, but if we look into large registries, we see that the mortality in hospitals, so this is not 30 days, it's in hospital mortality, is 5.8% in repair in this Japanese trial, and 14.5% in replacement. So there is a significant burden, and this is especially true if we have a transpulmonary gradient or afterload mismatches. The operator experience also plays a role. The higher your operator experience is, both in surgery and in interventions, the better your outcome is. Tricuspid annulus detection can now be done by artificial intelligence. And I know that there is a second session, but you can see here that the latest echo software can automatically identify the leaflets of the tricuspid valve and also the annulus. So this is not traced, it's automatically detected by the computer and offers a landing zone or also intervention zone for the treatment. There are many more AI-enhanced procedure possibilities, and one is the overlay or the fusion of echocardiography, as you see on the right-hand side, into the fluoroscopy image of the cath lab or the hybrid OR. Tricuspid regurgitation challenges are that this is a very prevalent disease. It's a definitely undertreated disease, and medical therapy is very limited. We only have diuretics and SGLT2 inhibitors, which show some effect, but there is no other proven medical treatment. The other situations are that functional TR offers an increase in the relative risk of mortality, as we see on the left-hand side. We also see that there are temporal trends for the surgical volume, which is also increasing. Sales for annuloplasty are increasing with the awareness that we have to treat this disease. So just recently, last year in May at the ACC, there has been a larger trial, which was the Triluminate trial, which showed that we're able, also with transcatheter methods, to actively reduce TR, and this is the TriClip study, and this showed a improvement, and the whole study, positive result of the study, was only driven by quality of life improvements. There were no 6-minute walking test improvements, there was no mortality improvements at 1 year, but a huge crossovers. Another trial performed in France, the TRIFR study, showed actually in the comparison between guideline-directed medical therapy and TR also quality of life improvements, but a very low event rate of mortality. So if we look at the whole group, the all-cause 1-year mortality was in the range of 3 to 4%. So it's very hard to find differences in these very well-selected patient groups, as you see here. There are larger European registries, like the BRIGHT registry, with more than 500 patients, and you can see that in transcatheter therapies, the cardiovascular mortality at 30 days here was 0.8%. So again, TEER offers an extremely safe alternative to treatment. We can also see that in this sub-analysis, tricuspid regurgitation, gap size, tethering distances, like in surgery, actually influence outcome and the results. Another so far under-respected etiology is CID, that means pacemaker or ICD lead involvements of the tricuspid valve. As you see here, this may be a perforation, this may be a gluing to the leaflet, and these also cause, in a range of 14 to 30% of the patients, a severe tricuspid regurgitation. Patient comorbidities may be an issue, as you see here in a patient that already had a TAVR procedure. We can see that T-tier may close the gap. We have seen this nicely in the case from Saudi Arabia with the Pascal device. This is a situation where XTW, so the stainless steel version of the TriClip, has been used, and I must say that, of course, this also has a high adaptation of the leaflets, so there is not a leaflet tear situation in these patients. And the reduction of TR severity was closely related to outcome and mainly quality of life issues, as seen in this slide. So I will start with another case presentation of a 85-year-old female that was admitted with heart failure. Her eGFR was borderline with 50 milliliters per minute. She had a 4/5 regurgitation in the Hahn classification, a Euroscore 2 of 4.2%, and an annulus that was in the range of 5 centimeters. So you can appreciate that this is a really massive to torrential disease in this patient. There was a mild pulmonary hypertension of less than 3 Wood units, which is beneficial to these patients. If we treat this, you can see here the mentioned view, which is the inflow view on the left-hand side with the aorta in the middle, and on the right-hand side is a biplane-derived four-chamber view, which is the grasping view in this patient. So a very severe situation, almost 5 centimeter annulus width, so a little bit more advanced. As you can see here, we use a transgastric view in order to subdefine the leaflet morphology, which can be bicuspid, tricuspid, and range up to 6 different subleaflets, as you can see here. And the subleaflets are being separated by papillary muscles, which are mainly located on the lateral side of the tricuspid valve. This is another possibility to actually engage here in the TriClip scenario. You can nicely see that we steer with artificial intelligence and three-dimensional reconstruction directly down to the valve, and we get cut planes that identify the tricuspid annulus level below the aorta, like in this case after surgery for CABG, which is easy to steer, easy to get a correct alignment, as you can see in the upper image, which is echocardiography, and you can treat these cases typically in 20 to 40 minutes. This is the transgastric view showing a TriClip XTW approaching to the leaflet. On the right-hand side, you can see the separation and how deep this device is below the leaflet tips. After treatment, the first device is being deployed. You can then use a second TriClip in order to further approximate the opening and to reduce the gap. And if we look at the result, this is pre on the left-hand side, and on the right-hand side, in a second, you will see the results. Sorry, can you put this back once and start the right image, just that we can appreciate the situation? Please, from the technical side, just let the right image run. You've appreciated the pre-situation. Pourriez-vous démarrer le vidéo à droite, s'il vous plaît? Excuse, la technique. Pourriez-vous m'aider de démarrer la vidéo à droite? Voilà. This is the result. So there's trace TR in this very large situation, so a surgical-like result. So we do not have to fear any other situations there. It's relatively good. And this is the TR with a pacemaker. And you can see that with the nitinol spaces of the brackets here in between, you can also jail pacemakers in between. This is not as advisable for ICD leads because the ICD leads are much stronger and you will produce noise into the recognition system of ICDs, but it's a very stable situation, very positive situation where you can dissolve the interaction with the leaflet from pacemakers, and you can see the result here, which is actually a jailing between the nitinol baskets at the XTW clip, and this patient had 0 TR afterwards. We know that there is sustained TR reduction. This is also true for the Pascal device, as has been shown in the Life in the Box case here from the CLASP TR study. And just for a short note, this is how this device is being steered, and we have seen this already in the live case, so I'll quickly run over this. We can accentuate the clasp separately on each side and do a so-called Tarzan maneuver over to the septal leaflet. The leaflets are engaged, we approximate to the septum, both sides are put down, and then you intentionally close the device, approximating both leaflets and creating a cooptation zone with very good result. In this case, this is pre on the left-hand side, a massive situation, and on the right-hand side, you can see that there are some trace jets in between. Very good recognition, and you see a very good right ventricular movement. And this is a 2-year follow-up in this case. And again, I would ask the technical part. Oh, no, it starts automatically. You see 0 TR after 2 years in follow-up. So these techniques are very, very efficient. So I come to a conclusion, heart team involvement outside pure age considerations. Cardiac surgery has a more than 3-decade, up to 4-decade experience, of course. Beating heart surgery on pump reduces mortality and also the AV block rate. Annuloplasty in surgery is the cornerstone. But tricuspid tear intervention has more than 15,000 human procedures now. Safety is extremely high. 30-day mortality is less than 1%. And TR reduction is so far stable in the trials, up to 2 years in the Triluminate trial, B-Right registries. I also would add, do not treat too late. Thank you very much for your kind attention.
Thank you, Professor Van Baarde-Lubben, for the nice talk. And I'd like to add that we are very lucky to have you with us in this After Noor, Professor Van Bardeleben is specialized in structural congenital valvular heart disease, and he's working in a great center. It's a main center in Germany. It's a leading center for percutaneous valve therapies in Europe. And this center participates to the majority of trials about mitral clip, TriClip, Pascal, Evoque, TAVI. So don't hesitate to ask your questions. We have with us all the distinguished experts in structural valvular disease. We will move to the discussion of the first session, and then we will move to the second part of the session. So do you have any questions? Don't be shy.
Thanks a lot for this good presentation. So we have almost the same problem in evaluation of this tricuspid regurgitation. I think this depends also on the load condition. So what do you think? In some cases, you have a patient with leg edema, with heart failure, right heart failure. We really make diuretics, SGLT2, and then we have almost a tricuspid regurgitation at not torrential, but really symptomatic tricuspid regurgitation. So must we really treat this patient with interventional treatment, or we must follow up them? So this is the first question. The second one, and as I said this today, we have also rheumatic valve disease. And this is a big problem in Tunisia, because not the valve are, we have a restriction, we have calcified valve, we have really, is it suitable for some techniques, and what really recommended in these patients?
I would start, and I think I give the first question to Augustin, but I would start with the second question. I think for rheumatic disease and situations where you have stenosis and regurgitation, like this morning in the mitral session, this is a clear-cut indication to go for replacement. So we will cover this in the second part of the session. The first part is more the regurgitation, and in the tricuspid valve, calcification and stenosis is more rare than the mitral space. So mitral stenosis is more common, at least in the Western world, on the European part, where I'm most, of course, experienced in, than in the tricuspid field, where I personally rarely see, and I see thousands of patients per year, where I rarely see too many calcified valves, but we see, of course, restriction, and we see stenosis. And if this is the case, as I said, I would go for a treatment. And the combined cases actually are handled very, very badly long-term by pure medication. Because the atria get large and larger, they displace also the other chambers of the heart inside the pericardium. So right heart disease leads to underfilling of the left heart, and it leads to a very bad interventricular coupling and contraction. So I would say any right heart disease also influences a low output situation to the left heart. This would be my points, and I hand over to Juan, to Walid, and to Augustin, primarily for the first question.
Yes, thank you very much. Speaking about the evaluation of TR severity, we need to be humble first, because it's tricky, actually. And of course, we all know that we have patients coming in ICCU with very torrential TR, let's say. You give diuretics, and then in the end, they're going to find you severe or moderate TR. The first thing, if you have a patient with severe TR one day, it is likely that he will come back again with severe TR. First thing. Then, of course, you know that everything can change with loading condition, with breathing, things like that. So what I suggest, if you think that the patient has a moderate TR in the end with diuretics, is to follow closely the patient, because we know that it's going to progress within the year, within the months. So you can use biomarkers. You can also look at the patient closely at 3 months follow-up at the echo and try to keep it at a state of fluid, state of overload that has been the base condition, let's say. But yeah, it can change, but keep in mind that it's going to progress very quickly.
And I would just like to add, of course, if we treat early, we don't see the results early, but late. I think that these trials, and I try to be very objective, we don't have a lot of data to support a lot of interventional treatment. And I think that we still need diuretic response in order to get also interventional response, Juan. Do you agree for that?
The biggest challenge, and there was a couple of slides that you presented, Agustin, that were very, very interesting, and is that you call progressors and regressors, is the dynamic changes that happen on the right side. At least on the left side, if you have a patient that comes to you and says, I'm short of breath, you can really be objective in terms of the indication for treatment. On the right side, if you go by symptoms, you're going to have to wait until the patient is really in a bad stage before you start seeing an impact. So one of the biggest challenges that we're going to have on tricuspid intervention is that to design studies that in a meaningful way show a strong efficacy response, we're going to need more sophisticated ways to measure the severity of TR, including hemodynamics, RV performance, and all these sophisticated stuff, because just the quantitative way that we're measuring TR right now is not going to be enough to be really, truly able to say we're making a therapeutic impact. We believe we are, but the regulatory agencies and payers will ask, show me the quantitative data. And I think that we need more sophisticated ways to measure that.
I have a question rather than a comment to discuss together. Guys, we have a lot of combination of MR and TR coming in our valve clinic, and I think it's the same in Tunisia. So can you comment on your strategy? Are you staging? Are you treating in the same time? What will be your strategy, Stefan, Juan, and Augustin? I know that it's debatable as a topic, so that will be nice to discuss with our friend from Tunisia.
I think there's a strong interaction, and it's a pity that we have parallel sessions actually with our heart failure specialists that should be here and with our electrophysiologists that should be here in this session. Because if we look into the trials, we actually overestimated the amount of HFpEF patients because we tried to have isolated TR. And the problem is there is almost no isolated TR. Isolated TR in the trials is HFpEF, heart failure with preserved ejection fraction, and long-standing atrial fibrillation and large atria. I think we have seen in the trials in the BRIGHT registry and to illuminate in the CLASP trials, and I was involved in every of these trials, we try to have a good LV function, we try to have no MR, and we try to have an isolated TR. And this is something that almost doesn't exist. We have to remember that 70% of TR is induced by left heart disease, being by half myocardial and by half valvular. So aortic stenosis, mitral stenosis, mitral regurgitation produces all TR, and AFib produces TR. So if you don't rhythm control the patient, and you have a patient that is elderly, and those are mainly women. Actually, it's a gender disease. Tricuspid valve disease is the only valvular disease that is much more common in women, and they are typically not seen by surgeons because they are 75 years and older. And they all have a history of 5 years of atrial fibrillation. They have huge atria, as been shown also by the case from Saudi Arabia. I think it's a very important point that we have to recognize that long-term untreated atrial fibrillation is bad. On the other hand, if you have tricuspid regurgitation or mitral regurgitation or stenosis, you will get 10% are in sinus rhythm. They will get the same disease and they will all get atrial fibrillation. So we have to get together in the multidisciplinary team that I showed at the beginning, and there the electrophysiologist is a major part to be co-treating these patients.
I have also another question to the first speaker. It's really nice to see that in Saudi Arabia you are building a good program. Are you doing only Pascal or mixed Pascal mitral clip? And if it's only Pascal, how can you comment on this choice? Is it because the device is easier to use, or I think Tunisia is starting programs now, and that can be helpful for them to know how you did your choice.
Yes, actually, I've said that we have chosen the Pascal for 3 reasons. And the third reason, actually, is that we are more familiar with the Pascal because that is almost the device we are using for our mitral cases. And you know, if we are starting a tricuspid program, preferably we will use something. It's not the time to discover another device, I think. But there are many other reasons why to choose the Pascal. I'm not advocating the company, but it is a much easier, I think, much easier device to use, especially if we have the experience of it in the mitral side, if you have the experience of the device itself for the TAVI. So it's quite intuitive in terms of manipulation, and it's a quite, I would say, gentle device on the leaflet. So that doesn't mean that the TriClip is not a good device, as shown by Dr. van der Lieben, but probably the Pascal is easier to use for someone who is just starting his experience.
I would question this a little bit. It's a little bit marketing. So I would be very cautious with, I've done 500 cases in tricuspid. I've done 100 cases also in Pascal. So I would be very cautious with this remark. I don't think it's much easier. Both devices, there's no data on the comparison of leaflet damage between the 2 devices. So we should be a little bit more neutral, I think. And I would say both devices do their job. There have been comparisons. There have been also trials with both devices, and they achieved almost the same efficacy and the same safety data. So I would not put the point here to say this is more gentle to the leaflet. This is marketing of one company of the 2. And I would be very cautious to make these sentences twice, okay? So please, if you present me data, I'm looking into the data, and you can repeat this again next year. But please, just look on data, not on a company advertisement, okay? Thank you. Yeah. So I think now we will move now to the next very important part in tricuspid disease, and this is a life-in-the-box case of replacement, and actually answering some of the questions that we've seen here. And it's my great pleasure that Augustin is replacing Thomas for this life-in-the-box case, and I'll be happy that we can discuss these new options that we see here. Augustin, please.
Thank you, Stefan. I've been asked to replace Thomas to present you a case of TTVR using the LuxValve Plus system. So just a brief presentation of the system. So the LuxValve system Plus is a self-adaptive braided ring which can help to solve the problem of PVL in some patients with big annular dilation. The second point is we have a multiple fixation design. You have 2 grippers, let's say 2 rabbit ears, that we can put them below the leaflets, and also an interventricular septal anchoring. And I'm going to show you this. You have also a bovine pericardium leaflets with anti-calcification treatment to improve the durability. And compared to other TTVR devices, it's a device with a steerable system coming through the jugular access. They had indeed a first generation using transatrium access, but now we have this LuxValve Plus system, which is a second generation. 31 French size of the delivery sheath. And we have ongoing trials called Travel 2 and Trinity to explore this system. This solution can offer us to solve current clinical challenges. The first one is very large annually, because with LuxValve, you have sizes up to 30 millimeter. So it can effectively cover all the anatomical deformation. We can have also a pacemaker lead that can interfere with intervention, but this LuxValve system has a 2-layer design which is flexible enough to work together with the leads. The image quality can be an issue too, and with these systems, you have only to check the clips and the septal anchor. We're going to see this just after. And of course, you can allow post-procedural pacemaker implantations. Just a quick presentation of the latest data presented and published in JACC Intervention around the first compassionate cases, 76 cases. You can see that most of the people were very old, 70 years old. 36% had prior cardiac surgery, and very high tri-score at 6. Most of the presented with edema, half had ascites, and of course they were really symptomatic because it was compassionate use. And at 1 month follow-up, we've found that very low rates of conversion to cardiac surgery for early use, only 5.3%, only 5.7 new pacemaker implantation, few in hospital deaths, and of course, durable TR reduction to less than 2+ in 95% of the patients, with significant improvement in NYHA functional class. I'm going to skip this, and we have a lab in the box from Bordeaux, and then we have a case from Lille. This live in the box is really short, only 5 minutes. So you can see that in Bordeaux, they are using this fusion imaging with, it's called EcoNavigator. You can see the art on fluoroscopy. So you already have this jugular access. Then we're going to use transfocal views to assess the mechanism, which was mainly a primary TR with a prolapse. And then after, they're going to advance the device into the right ventricle. They're going to cross the annulus very fast. They're going to advance, and of course, once you are in the right ventricle, you need to check coaxiality. You can use 3D to check the coaxiality here. They're going to use also MPR to check if the device is perfectly centered and aligned with the annulus. Then you're going to expose the two grippers, the two rabbit ears, like that. Then you need to check that these two rabbit ears are below the level of the leaflet and the annulus. You have two, you have one anterior and one posterior, so you can check this using biplane and MPR techniques. Once you are happy, you can deploy the atrial part, the ventricular part, sorry, of the device. You can see there is no rapid pacing. It's a smooth deployment. You want to add
Perhaps
something?
just for the steps, the overlay that we've seen was the same that I showed. It's a combination. So the red line was the tricuspid annulus line.
sorry.
The orange one is the right ventricle with the outflow tract. So you see up to the pulmonary valve. And the yellow is the right atrium. And the interesting thing is that you deploy the two rapid ears first. So one ear goes into the anterior leaflet, one in the posterior leaflet. And there is no need for a septal leaflet anchoring. That's very important to know about this valve. So even if the septal leaflet is totally tethered, we cannot do any Pascal or tri-clip anymore, this valve system still works because the third anchor is to the septum itself. So, and we will see it now here. Perhaps this is what you see on the lower here, this coming out of the device, and this is a tripod, like an anchor in a ship, naval ship. So it's a tripod that is shoot out through a patch into the septum between the right and the left ventricle, and it automatically inverts and keeps with the 3 pods a pressure against the septum. And this is seen, or was seen here, and it's below the nose cone that you see here. Now the nose cone is restricted, and you still see the septal part in the image in the fluoroscopy on the lower left, just for understanding.
Yeah, of course. I'm gonna just, it was a case from Bordeaux, very short case, let's say only 5 minutes, and I wanted to share with you a case we've done from Lille, a compassionate case, because, I mean, we discussed with Ralph Stefan during the steering committee for Trinity. This patient had a neuroendocrine tumor with severe pulmonary regurgitation and severe tricuspid regurgitation. She had a treatment for this tumor, and the level of blood markers were very low, meaning that the disease is stabilized. We decided first to perform a TAVR in the pulmonary position, and then the patient remained symptomatic, no recent heart failure hospitalization. She was in very good condition, no cognitive disorder, and furosemides were maintained at this level. As you can see here, it's like a restriction, very important restriction of the leaflets. It's kind of rheumatic disease. That's why I wanted to share this with you. You can see the very big dilation of the right ventricle and the big hole in the middle of the tricuspid valve. You can see pretty well the restriction, and it's challenging because we have also tethering of the leaflet. The subvalvular apparatus is thick, very restricted. But we decided to move on. So the delivery system was still into the right ventricle with gradual curving. We checked the coaxiality using biplane and NMPR. And at this point, the base of the graspers needs to be around 1 centimeter ventricular to the tricuspid valve annulus. Then, as you can see, the sheath is retrieved and the graspers are exposed. And you can check the anterior and the posterior graspers. As you can see, using this, I don't see if it's obvious. Let me check with the pen. No, it's not working. So you can see pretty well using this MPR technique that both graspers were below the annulus, close to the leaflets. And then the arterial cut is released, and at this stage you can make some final adjustment to minimize the PVL. And then you're going to deploy this septal anchor, as perfectly shown by Ralph Stefan, and you can see using this transgastric view the septal anchor highlighted by the yellow arrow. And in the end, for this patient with very restricted leaflet, we had a very good results with trace PVL at the anterior part of the device. You can see here the final deployment, and we did the case by the end of August this year, and I saw the patient a couple of weeks ago, and as you can see, we have very important reverse remodeling of the right ventricle. We have also preliminary results from Travel 2 presented by Thomas at New York Valve for the first patient with very good survival at 6 months, a sustainable reduction in TR severity with only 77% of the population had known or traced TR at 6 months. And this reverse remodeling was already observed with this population. And that's it. I wanted to just conclude.
Yeah, just short conclusion, yeah.
Short conclusion. I mean, this technique is promising. We have special aspect, transjugular access, the grippers, septal anchor, and reliable results, and we are waiting the data from Trinity. And we have the luck to have Stefan.
Augustin, thank you very much. Excellent case. Both live cases were excellent, also the Pascal case. And because of a matter of time, we move directly to the last talk from Juan Granada. And this is about this topic, TTVI, tricuspid transcatheter valvular intervention. Is it finally the solution to treat TR? And this goes well to your question.
Right, I hope I'm not very repetitive, and what I'm going to try to do with the last talk is to wrap things up, and as we did for the mitral, to talk a little bit about the future and the trends in our field. So this is what I see. This is the state of transcatheter tricuspid valve intervention in 2024 and the implications for innovation. I think when it comes down to technique adoption, in terms of technique adoption, I personally feel that favors replacement. And the reason is because it's a technique that is more reproducible and more standardizable. TEER is without any doubt a very safe procedure and is actually reproducible. On the right side is actually more difficult to standardize. When it comes down to procedural success, I would actually say that it's more of a tie because you get better TR resolution with replacement, but you have much actually higher procedural safety with a repair. The issue is when it comes to clinical outcomes, I also call a tie. Because if you go and compare the data that we have right now for death and rehospitalization, there's no significant impact in randomized control studies, and functional status, I think it's fair to say that both are equally effective. So this is kind of a summary, a high-level summary of what I see the state of tricuspid valve intervention is, right now. Now, what is the issue or the opportunities here? Replacement adoption appears to be growing faster. And the reason is because, as you actually saw in this session today, the tricuspid anatomy is so complex that essentially operators see an easier actually path forward replacing the valve than essentially going into complex repair procedures. Also, we have more therapeutic options. We saw Pascal, we saw MitraClip. I can tell you right now there are at least 20 tricuspid replacement programs that people can use. And in a way, there is also technical satisfaction. Replacement in a way is easier to use, is friendlier imaging requirements, is a very satisfying technical result. And let's face it, abolishing TR is just very cool. People really like the fact that you completely abolish TR. I think that a big breakthrough, and I really call it a breakthrough, that was presented at TCT this year is the TRISCEND 2 results. I think it's important because this sets the baseline of the future of replacement. I'm not saying that actually the results are going to change practice completely, but at least we already have randomized controlled data that is going to help us to build the evidence as we move forward. In the TRISCEND 2 trial, we got 267 patients on the replacement side and 133 controls. And as expected, there was a significant abolition, complete reduction of TR that essentially was maintained up to 1 year. This is not actually surprising. But when you go into the primary and safety effectiveness endpoint, you see that the biggest benefit was derived primarily by quality of life metrics. No differences, significant differences in mortality, no significant differences in heart transplant, tricuspid valve intervention was slightly higher, and heart failure rehospitalization was not any different. So this is when actually some people say, well, it's quality of life, not significant heart differences in heart outcomes, but at the end of the day, this is very important because it's going to help us to move the field forward as new technologies actually come in. But this is the big but. In tricuspid replacement, there is an upfront cost that you have to pay to actually get those results. And if you actually look at the replacement group versus the control group, you will see a higher cardiovascular mortality, more bleeding because of the need of anticoagulation, and very importantly, a very high difference in pacemaker rates. And this is where dedicated new devices, as we saw before, come into play. And there are plenty of technologies with different concepts that actually promise to improve the outcomes of first-generation technologies. And we started to see this. I presented the Chinese experience with this device at TCT with 96 patients, and you see that now the pacemaker rate, at least in this series, came down to 2% with very low actually bleeding complication rates and actually very low mortality for a cumulative incidence of composite endpoints of around 15%. So you started to see that the issues of first-generation technologies start to get better with second-generation technologies. So what are the drivers of innovation at tricuspid side? Broader patient eligibility is extremely important and going to be a key driver for market adoption.
Achieving maximal TR resolution is highly desirable, but one of the questions is, should 0 TR be the ultimate goal? Maybe it's not actually needed. Procedural safety drives device use. There's no question about that. Is it worth paying the price of excess procedural complications on tricuspid valve intervention? Maybe not. And can new generation non-replacement technologies achieve replacement-like results while achieving the safety profile of TEER? Those are actually the innovation drivers that are moving the field forward, and we started to see a lot of technologies that are now under development that try to kind of fall in between, getting replacement-like results with the safety of TEER. And this is an example of a technology that is under development that is called the TriClover, that this is what I call a glorified, a TEER device that is more comprehensive. As you know, everything looks beautiful in animations. Is when you're going to do the case that you see that things are not as good as the animations were. But you can actually see this is an example of how technologies are evolving to improve the results of TEER, getting the safety of TEER, but enhancing the efficacy to get as close as possible to a potential replaced device. I mean, unfortunately, I cannot really move forward, but you get the concept. I mean, the idea is to put these pledgets that essentially is kind of like the Clover technique that the surgeons have used over the years and end up with a good result by maximizing leaflet apposition. Also, other technologies are trying to use more sophisticated devices for targeted tricuspid annuloplasty, and this is a well-known, presented in the past technology. It's called the K-clip, that essentially what it's doing is reducing annuloplasty by creating a bicuspid valve from a tricuspid valve with actually very good preliminary results that have been presented over 100 patients with better results than annuloplasty, that has been presented before. And another trend is what they call occluders, with the idea of essentially using devices to occlude the center of the tricuspid valve, and instead of having a final implant, you use the leaflets to increase the coaptation and reduce the potential of, leaving a full valve behind. And finally, this is the last group of technologies that is called, essentially CABL devices. This is for very, very advanced patients in which essentially you don't replace or repair the valve, but instead you reduce the burden of regurgitation on the systemic circulation by putting stented systems. What is interesting about these technologies, though, is despite the fact you do not intervene the tricuspid valve by essentially decreasing the hemodynamic or improving the hemodynamic conditions, the ventricle remodels and the TR actually improves over time in some of these studies. So final thoughts on tricuspid innovation. The game is not over, and I think is wide open, and I would say is more active innovation on the right side compared to the left side. But there are certain things that we need to take into consideration. I honestly strongly disagree that leaving significant tricuspid regurgitation behind is good. If somebody says that, is really not on the right zone here. I think we need to maximize TR reduction as much as we could. But is 0 TR really the goal and is needed for all patients? I don't know, maybe not. Procedural safety is a must, but we should not really compromise efficacy at expenses of device performance. We cannot really say because a device is safe, is going to be better because, we're going to compromise efficacy. Also, we need to avoid drinking the Kool-Aid too quickly, because clinical outcomes of randomized controlled studies, I showed you, this is great data, first preliminary data, but are not definitive. And all this data can be improved. And finally, fixing the anatomy may not be enough. As actually Stefan said before, we need better understanding of patient phenotypes, hemodynamics, and right ventricular performance. That's the reason why electrophysiologists and heart failure physicians are really needed to help us to move this field forward. Thank you again for staying this late. It was an amazing session.
Thank you, Dr. Granada, for this fantastic talk and with these interesting key messages. So before inviting Professor Van Baarle-Leben to give us the key message of these sessions, do you have any questions, any comments? Probably I will ask a question re-ask the question about the rheumatic tricuspid regurgitation. And I'd like to have the point of view of Dr. Van Bardeleben and Professor Granada about, do you have an experience about the treatment of rheumatic tricuspid regurgitation? Because in Tunisia, it's a need for us to have a solution for these patients, because our patients are developing tricuspid regurgitation after mitral valve surgery. And now we have with us our surgeon, Termiz is here also. And unfortunately, our patients are symptomatic, and the surgeon refused to operate them, the right side of the heart. So, because they are at high risk of mortality, and we are seeing our patient dying, waiting for a solution, because in Tunisia, TTVI isn't available, not yet available. And I think that tricuspid clip isn't the good treatment for our patients, because we have a mixed mechanism, the annular dilation, but sometimes we have the right ventricle dilation with the grid tenting, and with the rheumatic disease of the valve, which is very thick, and with the restriction of the movement of the subvalvular apparatus.
I think I give this question first to both heart surgeons, to Professor Tamise and Professor Ben Ali.
Professor Ben Ali is not anymore a surgeon, you know. No, but you know, I got this discussion with Juan 3 years ago, because we tried to do a meta-analysis to see how it's good, the replacement in the surgical field. And I started the meta-analysis, and the results were very bad, actually. That's why I stopped, and I never published the paper with Juan and Tomas. And now, in the transcatheter field, we are saying that the future probably is the replacement and not the repair. It's a little bit strange, as you know. As a surgeon, we did a lot of replacement, but a lot of endocarditis and a lot of thrombosis. And we are never able to anticoagulate this patient. I don't know how it will be the future of TTVI, actually.
In Germany, we would put water in the wine or drink only water. I have to say, and I showed the data, I think a lot of surgical mortality is caused by irregular diagnosis, because I think most patients or most doctors just see the regurgitation, and what Juan nicely said is the phenotype of the disease is not understood. We know little about right ventricular function. We know little about afterload. We know that precapillary situations are devastating to the patients. So my big advice would be to do a right heart catheterization, which is extremely cheap, before every tricuspid valve intervention, and especially before surgery, and especially before replacement. Because the rate of right ventricular failure, and here I have to be in a little bit opposing situation to my good friend Juan, I have mainly seen in numbers which were upper single digit, even after transcatheter replacement, are only seen after replacement. And I've rarely seen them after repair, be it surgical or be it transcatheter. So I would say TEER is extremely safe. And I agree with you, Juan, that we should not chase the 0 TR. We should reduce TR by at least 80%. And I've seen good results thereafter. We should not aim for not having a trace jet anymore or nothing. It is more important that the patient survives, but we have to be more clear on the indication. And I think in most instances, in most countries, I include my country, there is an insufficient workup of tricuspid valve regurgitation before treatment. And this would be my point.
And for replacement, for surgery, I think data are very clear. But were presented 3 years ago, the data from STS registry, and it's 30% mortality. So,
but one of the things is, you know, talking again about the phenotype of the surgical patients or the transcatheter patients are different. And one of the biggest issues is that, and I keep saying this because it's counterintuitive, it's so difficult to really show a clinical benefit of tricuspid intervention because it's kind of a silent disease. That's the reason why, you know, we neglected a tricuspid valve for quite some time. That if you add peri-procedural complications related to surgery, then the benefit goes away.
And it's the same for TTVI.
Exactly,
you
no,
show
but
very
one
well
of the
with
things
Troisen.
is, exactly, but one of the things is when you reduce, you know, infections, bleeding, and all these things with transcatheter stuff, then you kind of equalize the thing, but it's still, unless we figure out what is the patient that is going to benefit from it, it's going to be very challenging to move the field forward.
Yeah.
Thank you very much. I think because of time, and we started 10 minutes late, we're closing 10 minutes late, but we want to pay respect to the coronary interventions, which will be a short session before the cocktail reception tonight. I would just shortly summarize. I would say the tricuspid valve is the no longer forgotten valve. I think it's the biggest, one of the biggest new horizons in cardiology. And I invite you to go further into diagnosis, and this is looking at your patient, whether they have leg edema, fatigue, very unspecific symptoms. Do an echo on these patients and follow them up. Also, I advise you to follow up every patient that receives a pacemaker or an ICD, because a lot of them will develop tricuspid regurgitation over time. And it's important that the electrophysiology community accepts that an echocardiographer belongs to cardiology, and also electrophysiology belongs to cardiology. That's my second big point. We have learned that even though it's very expensive, we also know that the stents, drug-eluting stents in the past, 20 years ago, were $2,000 US. Now a coronary stent, at least in Germany, is less than 100. It's 70 euros. To buy a drug-eluting stent. It's cheaper than a bare metal stent. So do not skip innovation, because innovation will always become cheaper. So I would say for the next point, TEER will become a reality in Tunisia. That's a very important point. The last point is TTVI will also come to Tunisia, but it may take 2 years longer, because also in Germany, it's excessively expensive. So to do a TTVI is 2 times the amount of money, also in Germany so far, than TTIR, and it's about 4 times of surgery. So just that you have an appreciation of the prices, but also this technology in 2 years, 5 years' time, because there's already production in Brazil, there's already production in India, and there's production in China, as we've shown you. There will be competition, there will be cheaper prices, and it may be easy that these prices will fall by 70%. So there is a bright future ahead. I think it was an excellent session. I thank my co-moderator, Professor Habib. I thank all the panelists who were excellent, and you as an audience who was here until late. And I hope you find this session attractive, interesting, and that you will come also next year to the Tunisian Cardiology and Cardiovascular Surgery Summit in order to learn even more about these forgotten entities. Thank you very much, and I close the session.
Thank you. So we'll move to the Sanofi Symposium.